Welcome to Virginia Medical Updates. My name is Alejandra Gonsalves, and today we will be discussing again cardiovascular risks and disease prevention. Today we have with us our very own Dr. Madhu Henry. Thank you for joining us today, Dr. Henry. Dr. Henry is a graduate from George Washington University, and she's been a primary care physician for 14 years. Today we're going to discuss the cardiovascular disease risks and prevention. And we had touched on this subject when Dr. Henry was last with us. And some of the things that we discussed were 9 modifiable risk factors. And we were spending some time on the importance of diet. So Dr. Henry, thank you again for coming. And let's discuss one of the first risk factors that we mentioned was smoking. How important is that on preventing cardiovascular disease?
Sure. I think that you had appropriately identified the fact that some of our modifiable risk factors are choices. Smoking is a great example. You have people out there that are making a choice. There are many studies out there that show that cigarette smoking is the leading avoidable cause of premature death. It's a major avoidable cause of premature disability. The other thing that I think is more compelling is that the amount of cigarettes currently smoked increases morbidity and mortality for cardiovascular disease. Another way to look at this is if you decrease the amount, you also decrease the effects. So oftentimes patients will come to us and think it's an all or nothing, but that's not the case. You could be a pack-a-day smoker and we could reduce to half a pack and still reap benefits from that reduction.
Okay, but of course the best option is going to be to actually quit smoking. So if someone is looking for, for smoking cessation to stop smoking, what is that they can do,
in that area?
Right. What else could they do if they come in to see you and talk about that?
Yeah, the benefits of cessation begin to appear after only a few months and reach that of a non-smoker within a few years. So I like people to think of a provider or the relationship with the provider as an opportunity to problem solve. You're intelligent, you are aware that this is a risk, it's not a new discovery, but thus far you've lacked success, and that's very common. In fact, studies have proven that it takes 8 failed attempts before you're at being successful at quitting smoking. Yeah. So I'm here to help you problem solve, and some of the modalities that I choose or I try to make available to patients or make them aware. So education, I try to educate them about behavioral modification. Oftentimes when a patient is desiring to quit, they need to prepare for it. Just like you prepare for anything big in life, you might need to pick a quit date. You might need to think about alternative activities you're going to do instead of smoking cigarettes. So it's to kind of bring their awareness to, oh, this is a process, and for success I have to plan for it.
Right.
With that, there's also medications. There are nicotine replacement options. There's several modalities. There's gums, there's patches, there's lozenges. There's a lot of opportunities there, and most recently now we have several pharmacological therapies to aid and assist. Some of the therapies are used to just make smoking less desirable, to decrease craving, and some are to actually give negative stimulus. So a patient, it's almost like a shock. The patient gets shocked and says, hey, that felt yucky, I don't want to do this anymore. But again, here's an opportunity to come in and discuss this and see how can we problem solve this together.
Okay, so there are other options, and you mentioned activity. I know that obviously that's something, physical activity, that seems obvious as something that someone could do to lower their risk for cardiovascular disease. Can you talk a little bit more about that as well?
Sure. I think that physical activity is always one of those that is kind of misrepresented. Many times we have patients who think they got to join a gym and they've got to get in 6 days a week and 60 minutes a day, or what's the point? An area in my resources when I was studying for this was, which I like to present and like to bring forth, was the idea that any exercise can benefit you, and that now we sort of quantify exercise. So many times we will describe exercise as by time spent. What that means is you can have people who have moderate intensity of exercise, 150 minutes a week. You can have people who have vigorous intensity exercise, 75 minutes a week. But then we have patients who are possibly limited exercise capacity. They've had some medical condition, neuropathy, or possibly suffered an injury or osteoarthritis. They're not able to weight bear. So we offer modified exercise strategies. The thing that I think is really important to keep in mind, though, that people who self-describe themselves as ones who work out are known to have decreased morbidity or mortality from a cardiac event. And these early childhood programs like PE that you go in grade school are known to show to decrease coronary risk, cardiac risk over time.
Okay, so later on. All right. So, yeah, so of course we know smoking, as you mentioned, and physical activity. If we can hopefully do that, then, obesity is hopefully not a factor if we're not, if we're trying to keep up with the physical activity. So for those who are obese, how does that affect their risk for cardiovascular disease?
In June of 2013, the American Medical Association made a controversial decision to qualify weight. They decided to do it by something called the body mass index.
Okay, yes, your BMI.
Exactly,
right.
Your BMI. So the BMI takes into account height and weight. It's not just your weight. So the BMI was used to kind of take into account that there are different body sizes, there's different fat and water distribution within the body. And it's given us a new parameter to talk about health and cardiovascular risk. So as opposed to being an ultimate one goal in weight, we've started to use a scale. The scale is on a 30 and plus point scale, but basically a score of a 19 as your BMI is considered underweight. A score of 19 to 24 is a normal weight.
Okay.
25 to 29 is overweight, and that's when we should start getting engaged in this. And a score of 30 comes that ugly word obesity, so obese.
Okay, but 19 to 24 is where we want to stay at. That's the goal.
Exactly,
okay.
Exactly.
Okay, so now we've discussed the choices that we can make as your patient.
Yeah.
And when we come in to discuss this with you, we can obviously, try for the physical activity, try to stop smoking, and work on losing some weight. But what about the aspects that are maybe not under our controls as much, our blood pressure or sugars? What can we do if that's not anything that maybe we're working on but we're not able to control on our own?
If we kind of go back to my original premise about this conversation, it was that cardiovascular disease is preventable, and it's preventable by modifiable risks. And those modifiable risks, one of them under the definition is hypertension. So I'd like to take a little bit of time to kind of define hypertension, but then to offer modalities of management.
And so for the hypertension, what can we do if it is something that is in the family?
Sure. Hypertension is defined as a blood pressure of 140 over 90 or greater. So when you go into the doctor's office and they put the pump on you and they get your blood pressure, the top number is that range of 120 or so, and the bottom number is a range of 80. 140 or higher or 90 or higher. So either number being high is considered high blood pressure. We as providers engage this when those numbers are between 120 to 139, that's considered prehypertension, or the lower number, the diastolic number, between 80 and 89.
Okay.
Again, the goal is for blood pressure to be under 140 over 90, and the target is 120 over 80. How do we achieve this? Weight reduction, salt reduction. There's multiple modalities of kind of attacking this.
Okay, so these are all things that we can do, but if it is still high, we can, like you said, the salt restriction and the weight. If it's still high after that, what is it that we can do if we come to see you in the office?
Sure.
Are there other options that we have?
Sure, and this is where we get into medications. So many patients are leery of it. They don't want to start medication. They say, if I get on a medication, I'll never get off a medication. You know, blood pressure is very sophisticated. It's not just your heart. Your kidneys are actually responsible for controlling your blood pressure. They're the sensing mechanism. So most of the medications are used, attack in a kind of single way. They either attack through the heart, they work through the kidney, or they actually simply just work to remove fluid, a diuretic to decrease blood pressure. So what I choose is very specific to the patient. But what the take-home point for me is, while you might be very resistant to doing a medication, think of the ultimate consequence of not doing a medication. People will always come in and say, but I don't want the side effect, I don't want the risks. What's the risks of not doing a medication? Sounds to me like it was a heart attack, a stroke, or possibly a infarct in your lung or in your lower leg.
And they could eventually come off of the medication if they're able to change those other risk factors that they can actually, the modifiable risk factors.
Absolutely.
So, and I know also cholesterol is another factor that maybe you might need to be on medication for. Could you touch a little bit on that as far as it having to do with cardiovascular disease?
Sure. Several large-scale randomized trials have talked about statins in individuals with clinical evidence of coronary heart disease, so blockages in the vessels of the arteries of the heart. They have shown to increase quality of life and decrease morbidity and mortality, decrease death in areas of stroke, heart attack, and other.
Okay, so that's an important
risks.
one as well. So of course cholesterol is one that we have to pay attention to, but I know diabetes, how can we touch on that and explain to everyone how important that is as a factor?
Sure. You know, the big take-home point with diabetes is to understand the macrovascular and the microvascular complications. Macrovascular is organs. How's it affecting my heart? How's it affecting my kidney? How's it affecting my eyes? The microvascular are the little vessels that are going around throughout the body. So people coming in with numbness and tingling in their feet, or blurry vision, something in a very small kind of area where blood sugar might kind of collect and cause a problem, right? So I kind of like to make that as the big point so that people understand what diabetes is, and then define it and try to tell people, you know, look for this, or this is what I look for in that screening physical.
Okay, so I see that basically we have to really make sure that our diet stays with lots, like we mentioned, fruits and vegetables, a lot of fibers, and avoid those donuts, avoid those sweets.
All the good stuff.
Yes, and in summary, those factors are basically to make sure that we're not smoking, have our BMI be lower than 25, and make sure that we're exercising. And we thank you very much, Dr. Henry, for being here. We've learned a lot today. I hope everyone has had a chance to learn something new. This has been Virginia Medical Updates. I'm Alejandra Gonsalves, and we hope to see you again next time.